Greetings and welcome to a presentation on a practical guide to static lung volumes and capacities, how they're measured and why they matter. I'm Bob Brown, the developer and content manager of the Pulmonary Diagnostic Laboratory Resource Center located at pftlabresources.com. The purpose of the Pulmonary Diagnostic Laboratory Resource Center is to provide select information to consider when developing programs to improve the delivery of healthcare services. The purpose of this presentation is to provide a clearer understanding of static lung volume and capacity measurements and illustrate how their targeted use can enhance diagnostic precision and optimize patient care. Since we all have different pulmonary diagnostics backgrounds, it's my hope that this information will either be new or reinforce what you already know. I've included numerous suggested readings at the end of the presentation so that you can readily assess how I came to the conclusions addressed in each section. If you have additional, compelling, peer-reviewed published information on this topic from either Scopus or PubMed, please send it to me. My contact information can be located in the contact section of my website listed here. The slides are numbered on the bottom right. If you need to leave the presentation, you can always note where you left off and pick it up from there later on. So this presentation is about 45 minutes in length. If you haven't done so already, grab a beverage, a snack, get comfy, and let's get on with the show. I have no conflicts to report. Okay, let's take a look at the focus of this presentation. These are the objectives of this presentation, along with the areas that will be addressed. Let's review some terms, definitions, and concepts associated with static lung volumes and capacities. For this presentation, static lung volumes and capacities refers to functional residual capacity, abbreviated FRC, expiratory reserve volume, abbreviated ERV, inspiratory capacity, IC, inspiratory reserve volume, IRV, residual volume, RV, tidal volume, either TV or VT, vital capacity, VC, and finally total lung capacity, TLC. The term lung volume or static lung volume usually refers to the volume of gas within the lungs as measured by body plethysmography, gas dilution, or washout. In contrast, lung volumes derive from conventional chest radiographs, which are usually based on the volumes within the outlines of the thoracic cage, and include the volume of tissue, whether normal or abnormal, as well as the lung gas volume. Lung volumes derived from CT scans can include estimates of abnormal lung tissue volumes, in addition to normal lung tissue volumes and the volumes of gas within the lungs. The FRC, the functional residual capacity, is the volume of gas present in the lungs at end expiration during tidal breathing. The expiratory reserve volume, the ERV, is the volume of gas that can be maximally exhaled from the end expiratory level during tidal breathing, in other words, from the FRC. The maximum volume of air that can be inspired from FRC is referred to as the inspiratory capacity, the IC. The inspiratory reserve volume is the maximum volume of gas that can be inhaled from the end inspiratory level during tidal breathing. RV refers to the volume of gas remaining in the lung after maximal exhalation, regardless of the lung volume at which exhalation was started. The volume of gas inhaled or exhaled during the respiratory cycle is called the tidal volume, abbreviated either VT or TV. The thoracic gas volume, the TGV or VTG, is the absolute volume of gas in the thorax at any point in time and at any level of alveolar pressure. However, when static lung volume measurements are made, the VTG is obtained at resting end expiration, in other words, the FRC. The vital capacity, VC, is the volume change at the mouth between the positions of full inspiration and complete expiration. And TLC refers to the volume of gas in the lungs after maximum inspiration, or the sum of all volume compartments. While understanding the importance of all terms involving static lung volumes and capacities, for this presentation, I plan to primarily focus on these terms. This illustrates a relationship between lung volumes and capacities. Notice how two or more volumes make up a capacity. For example, inspiratory reserve volume, IRV, plus tidal volume, TV, plus expiratory reserve volume, ERV, equals vital capacity, the VC. At rest, a predictable balance exists between the lungs and the thoracic cage, where the continuous recoil force of the lungs is equal and opposite to the outward recoil force of the chest wall. That is, the lungs are constantly trying to collapse and the thoracic cage is constantly trying to expand. This relationship defines the FRC, the amount of air remaining in the lungs at resting and exhalation. As with any test for static lung volume, certain limits exist. It's incumbent upon the technologist administering the test, as well as the physician interpreting the test results, to realize and appreciate how the data are derived and reported. Some limitations associated with VTG include, but are not limited to, the following possibilities. Overestimation of VTG in subjects with moderate or severe obstruction, which is minimized with appropriate panning frequency. Erroneous measurement of VTG owing to improper panning technique. Computer-generated VTG slopes may be inaccurate if extraneous data points are included. Excessive abdominal gas or panning techniques using accessory muscles may increase the VTG owing to compression effects. Careful calibration of multiple transducers is required. Attention to frequency response, thermal stability, and leaks is necessary. And the choice and application of reference values affects interpretation. Since all the gas in the thorax is accounted for, total body plethysmography is the ideal method for measuring static lung volumes in individuals with trapped gas, such as bullous emphysema. If subjects perform the VTG maneuver properly, in other words, they pant at less than or equal to 1 cycle per second when the mouth shutter closes, derived TLC values are equivalent to planimetered lung volumes, even in severely obstructed individuals. Due to methodological differences, however, VTG values may be nearly 9 to 10% higher than multiple breath gas dilution FRC measurements in normal and individuals with restrictive lung disease. This difference is accounted for because not all airways are patent at any given period of time, since there continuously exist small yet diffuse amounts of unventilated lung. Having a good appreciation of the indications for measuring static lung volumes and capacities is paramount. The indications listed here were derived from the ATS Pulmonary Function Laboratory Management Procedure Manual, the 3rd edition. If you don't have access to this important resource, I highly encourage that you would purchase it from the American Thoracic Society, as it's a must-have for anyone providing pulmonary diagnostic services. If you look at the last indication listed here, quantify the amount of non-ventilated lung. This may be an area that's not generally appreciated, say, as being a cause of unexplained hypoxemia. Let's next review some classification and causes of restrictive pulmonary defects. If you're unfamiliar with these classifications and you don't plan on returning to this video, I highly encourage taking some screenshots. First up, parenchymal lung disease. Next up, neuromuscular abnormalities. Followed by chest wall abnormalities. Continuing with space-occupying lesions. And finally, pleural disease. The percent predicted in this figure and the subsequent case studies is used to illustrate the relative contributions of static lung volumes and capacities for each example and not for interpretation purposes. The normal aging process increases the FRC. The FRC may also be increased in the presence of lung diseases that cause air trapping, such as in asthma, chronic bronchitis, and emphysema. Conversely, the FRC can be reduced in the presence of restrictive lung disease processes such as interstitial lung disease and pneumonectomy. TLC is the volume of gas in the lungs at the end of full inspiration. Inspiration ceases at TLC because the opposing recoil forces of the lungs and thoracic cage are again balanced. That is, the weakened inspiratory forces are unable to overcome the increased force necessary to distend the lung and chest wall. The exact opposite occurs at residual volume, RV. The vital capacity of the VC is maintained within the normal range with certain pulmonary diseases, for example, emphysema. The VC, however, is reduced in the presence of restrictive pulmonary processes, for example, ALS, chronic bronchitis, and asthma, especially moderate to severe asthma, as well as poor effort. The residual volume, the RV, may be elevated in some pulmonary diseases, particularly those that cause air trapping, and may be reduced with restrictive lung disease and falsely overestimated if ERV is reduced because of poor patient effort. Total lung capacity, TLC, is useful for differentiating types of lung disease processes characterized by airflow limitation, for example, obstructive lung disease, which have similar forced expiratory spirometric configurations, whereas chronic bronchitis has near normal TLC, mild to moderate asthma has reversible hyperinflation, and emphysema has irreversible hyperinflation. Hyperinflation is characterized as an increase in the RV to TLC ratio. Additionally, when there's a reduction in FVC and no evidence of airflow limitation, this suspected restrictive defect needs to be confirmed by measuring total lung capacity. Lung volume measurements are designed to determine the presence or absence of a disorder and, if an abnormality exists, to quantify the extent of the abnormality. They are also used to determine the best course of treatment as well as the effects of therapeutic intervention through follow-up measurements. For example, static lung volume measurements may be more sensitive than other pulmonary diagnostic procedures, for example, forced expiratory maneuvers, to detect the pulmonary toxic effects of some cardiac and chemotherapy agents. Unlike forced expiratory spirometry, the VC maneuver is untimed. The VC is oftentimes referred to as the relaxed vital capacity, the slow vital capacity, or simply vital capacity. It's measured from TLC to RV. Once TLC is attained, the subject is instructed to slowly exhale and to not perform a forced maneuver until the terminal portion of the expiratory effort, when considerable encouragement by the technologist may be necessary to have the subject expire the remaining amount of air. Let's take a look at how the inspiratory vital capacity, the IVC, is derived. After a number of acceptable tidal breaths with consistent end expiratory levels, the subject is instructed to passively exhale to residual volume. Once residual volume is attained, the subject is instructed to maximally inspire to total lung capacity. Remember, the subject should not be encouraged to force the air out until the terminal portion of the expiratory maneuver, when considerable effort may be needed to exhale the last 5% to 15% of air. Let's take a look at the expiratory vital capacity. After a number of acceptable tidal breaths, again with consistent end expiratory levels, the subject is instructed to maximally inspire to total lung capacity, followed by a passive exhalation to residual volume. Next up is the two-stage vital capacity. After a number of acceptable tidal breaths, the subject is instructed to maximally inspire to TLC. Once total lung capacity is attained, the subject returns to tidal breathing, followed by passive exhalation to residual volume. This method may be preferred with individuals who have difficulty comprehending or performing either the inspiratory vital capacity or expiratory vital capacity patterns. This graphic illustrates the relationship between inspiratory capacity and expiratory reserve volume in patients with emphysema. This disparity is seen because hyperinflation causes a reduction in the maximum amount of air that can be inspired from functional residual capacity. Please note that a similar pattern is commonly observed in patients having inspiratory muscle weakness. So some of the utility of the relaxed vital capacity is that the relaxed VC result may be compared with the forced vital capacity to assess the presence of air trapping. In this case, the VC would be larger than the FVC. The VC graphics morphology can guide the clinician to the type of lung disease being evaluated. For example, with emphysematics, despite severe airflow limitation during FVC maneuvers, the relaxed VC will generally remain within the normal limits because dynamic airway compression does not occur until the terminal portion of the VC expiratory maneuver. Additionally, because emphysematics breathe at a higher lung volume because of hyperinflation, they will commonly have a reduced IC with a larger component of their VC being comprised of the ERV. Chronic bronchitics and asthmatics will generally have reduced ERVs relative to their entire VC volume. Let's have a quick look at the relationship between inspiratory capacity and expiratory reserve volume in patients with expiratory muscle weakness, for example, ALS or high spinal cord injury. The subject is able to inspire adequately, but because of respiratory muscle weakness, the ERV is reduced. This reduction may cause an increase in the residual volume and total lung capacity ratio. Note that a similar pattern is commonly observed in patients with chronic bronchitis and asthma exacerbation, both of which cause air trapping. Now let's transition over to FRC derivation with the multiple breath nitrogen washout test. The multiple breath nitrogen washout FRC value is equivalent to plethysmographic FRC and compares acceptably with planimetry-derived TLC values in normal subjects and those with pure restrictive lung defects. Multiple breath nitrogen washout measurements may be indicated in those individuals who are physically or emotionally unable to enter a plethysmograph or when such equipment is unavailable. Additionally, multiple breath nitrogen washout FRC requires minimal patient involvement during the testing process. When possible, lung volume measurements should precede forced expiratory maneuvers, which could induce bronchoconstriction and thus shift FRC or reduce VC. And as a reminder, the VC maneuver should be performed during FRC measurement. This illustrates the multiple breath nitrogen washout test for functional residual capacity. Notice how the nitrogen decreases over time. It washes out as the subject tidal breathes 100% oxygen. This graphic provides a simplified view of what a multiple breath nitrogen washout test actually looks like. In practice, the full test includes far more breaths than those shown here. With the multiple breath nitrogen washout test, either the percent nitrogen or its logarithm is plotted against either volume, the expired volume, or the number of breaths. The final result of the FRC test is dependent on the distribution, the evenness of ventilation, which is related not only to the volume of the patient's FRC, but to the tidal volume, the respiratory rate, and the dead space, both anatomic and system dead space. Distribution of ventilation can be indirectly assessed by the length of time it takes for the patient to wash the nitrogen out of the lungs when tidal breathing 100% oxygen. There are a number of limitations associated with this test, which should be used as a guide for the assessment of patients as well as during the test interpretation process. Some multiple breath nitrogen washout limitations are as follows. Number 1. Some subjects are unable to maintain a mouth seal or cooperate adequately for the amount of time necessary to perform the test. Multiple acceptable FRC measurements are necessary, which increases test time. Adequate time needs to be allowed between sequential measurements to allow elimination of the test gas from the lungs, which is at least 15 minutes for nitrogen washout. Number 2. Certain pathologic conditions can cause a leak in the lung volume measurement system, such as a perforated tympanic membrane. Number 3. FRC measurements by gas elimination may be underestimated in individuals with airflow limitation and air trapping. These tests only measure the amount of air present in the communicating airways. Number 4. The elimination of nitrogen from tissues and body fluid can result in overestimation of FRC in healthy subjects unless appropriate corrections are made, approximately 30 mLs per minute of washout time. And number 5, some subjects are unable to remain off supplemental oxygen long enough, at least 15 minutes, to perform single or multiple FRC measurements. The presence of elevated alveolar oxygen tension interferes with the accuracy of the multiple breath nitrogen washout test for FRC. This is an illustration of how a leak is depicted during the multiple breath nitrogen washout test. With this example, the leak at the patient instrument interface causes a brief rise in the nitrogen concentration. During the testing process, any rise in the percent nitrogen warrants discontinuance of the test and results should be discarded. This is a depiction of a dead space or a small breath during the multiple breath nitrogen washout FRC test. This breath is acceptable and does not compromise the quality of the testing process. A dead space breath may naturally occur or after the subject performs an inspiratory capacity or vital capacity maneuver. This illustration depicts the effects of a physiologic leak, such as a perforated tympanic membrane, during the multiple breath nitrogen washout test. Note how the percent nitrogen remains constant and does not approach the 1% to 2% value, which would indicate end of test criteria being attained. The following case studies are from my teaching files that I collected while at the University of Wisconsin Hospitals and Clinics in Madison, Wisconsin. No subjects are directly identified during this segment of the presentation. This subject is a 34-year-old male, 72 inches in height and 196 pounds. He presented with a recent onset of extremity weakness. As can be seen from this data, static lung volumes fall within the broad range of normal. Despite his maximal occluding pressures being greater than predicted, his expiratory reserve volume is disproportionately reduced relative to his inspiratory capacity. After initial studies were performed, serial measurements were obtained approximately every 5 months to monitor disease progression. 22 months after his initial evaluation, his ability to maximally inspire and expire changed dramatically. The VC, IC, and ERV declined faster than what would be anticipated with the normal aging process. Respiratory muscle weakness was confirmed by a significant reduction in his maximal occluding pressure, where expiratory was greater than inspiratory. This respiratory muscle weakness contributed to a substantial change in his RV and RV to TLC ratio and was further confirmed and evidenced by hypercarbia, where his PaCO2 was equal to 48, with resultant hypoxemia with room air PaO2 of 61, which were not present during baseline studies. This subject is a 62-year-old male, 72 inches, 160 pounds. As part of his pre-surgical assessment, static lung volumes and capacities were assessed. Note the disproportionate baseline ERV compared with the IC, a hallmark of the effect of chronic lung hyperinflation associated with severe emphysema. Following lung volume reduction surgery, when assessed with the multiple breath nitrogen washout method, this patient's static lung volume subdivisions returned to a more equal distribution. Post-surgery voluntary volumes improved as evidenced by the increased IC. The surgical procedure reduced lung hyperinflation, resulting in a mechanical advantage to inspire. In addition, there was a reduction in TLC, and the RV to TLC ratio improved significantly post-surgery. When properly performed, the most accurate and perhaps quickest method for determining static lung volume measurements is to employ total body plethysmography. During the testing process, the subject is enclosed in a chamber equipped to measure either pressure, flow, or volume changes. The FRC measurement is commonly referred to as the volume of thoracic gas, the VTG, to distinguish how the measurement was derived as opposed to the multiple breath nitrogen washout FRC method. As with other static lung volumes, VTG is expressed in liters at BTPS. By definition, the VTG is the volume of air in the thorax at any point in time and at any level of thoracic compression. It's measured during the closed shutter maneuver. Although VTG may be determined at any level of lung inflation, it's most commonly determined at FRC. Now, just a quick note. While not addressed in this video, total body plethysmography airway resistance measurements are lung volume adjusted by measuring the VTG at which the airway resistance test was performed. While the subject is allowed to choose the lung volume to perform the airway resistance test, it's commonly performed at FRC, above resting FRC, or slightly below the resting FRC. That being said, airway resistance VTG should not be used to determine static lung volumes. Additionally, since the VC should be linked to the FRC measurement, performing a vital capacity during airway resistance measurements may cause an alteration of the resting airway resistance through relaxation or constriction of the airway smooth muscle. This graphic illustrates how VTG is derived using total body plethysmography. When the mouth shutter closes, the subject gently pants, alternately compressing and decompressing the gas in the thorax. Using a variation of Boyle's law, mouth pressure changes are plotted against box pressure changes, and the tangent is measured, which corresponds to the lung volume when the mouth shutter was closed, the FRC. Since there is no airflow during the closed shutter maneuver, mouth pressure approximates alveolar pressure. The VTG, therefore, is equal to the change in mouth pressure divided by the change in volume. The measurement should be made through the center of the closed shutter loop. So let's take a look at some common closed shutter loop errors. The reversed end tracing represents drifting box pressure and is caused in most cases by incomplete thermal equilibration. The chop tracing represents overranging of the mouth pressure transducer and is caused by the subject panting too deeply. The alinear tracing represents a mouth pressure leak produced when the subject is leaking around the mouthpiece, or the subject is pouching his or her cheeks during the terminal portion of each expiratory excursion. This pouching is easily rectified by having the subject use fingertips versus palms to support their cheeks. A completely horizontal tracing represents box pressure changes without mouth pressure changes. This is often observed by the subject's tongue blocking the mouthpiece, or by the subject essentially holding in a breath and simply moving their body, generally the shoulders. A completely vertical tracing represents mouth pressure changes without box pressure changes. This is often observed when the subject generates mouth pressure changes with the cheeks while not moving the thoracic cage. Now let's take a look at some applications of total body plethysmography testing. Body plethysmography is the only accurate functional measurement of static lung volumes, since gas dilution methods, for example the multiple breath nitrogen washout test, may underestimate true lung volumes in the presence of the following conditions. When compared with gas dilution FRC, thoracic gas volume quantifies non-ventilated lung. Accurate determination of static lung volumes is important for the following reasons. First of all, restriction is based upon TLC. Secondly, hyperinflation has diagnostic implications in obstructive lung diseases. And thirdly, hyperinflation may have an independent effect on the symptomatology in obstructive lung disease. Again, I have a disclaimer that the following case studies are from my teaching files that I collected while at the University of Wisconsin Hospitals and Clinics in Madison, Wisconsin, and no subjects are directly identified during this segment of the presentation. This is the same subject I've previously reviewed, a 62-year-old male, 72 inches, 160 pounds. Baseline static lung volume measurements illustrate how lung volumes may be underestimated if only multiple breath nitrogen washout methods are used. The TLC fell within the broad range of normal with the multiple breath nitrogen washout test but was elevated when measured via plethysmograph. Following lung volume reduction surgery, plethysmographic and gas dilutional static lung volumes resulted in a more normal appearance when compared with baseline studies and predicted values. Also, the ratio of unventilated lung, the VTG divided by FRC ratio, improved, but did not normalize. The normal ratio is generally considered to be less than 1.09. This subject, a 53-year-old female, 63 inches and 188 pounds, was referred for evaluation because of her complaint of increasing dyspnea both at rest and during ambulation. Inspiration chest radiographs showed reduced volumes that were confirmed by actual static lung volume measurements. Note the near symmetrical reduction in all lung volumes, which is a hallmark of a restrictive ventilatory defect. There was no evidence of airflow limitation with forced expiratory spirometry. Obviously, that's not shown. And at the time of this testing, this subject was undergoing lung transplantation evaluation. This subject, a 17-year-old male, 71 inches, 110 pounds, was referred for evaluation of his progressive disease. Voluntary volumes are decreased with maintenance of FRC. Note the increased RV and RV to TLC ratio that are a result of his inability to adequately exhale due to his respiratory muscle weakness. Not shown were his FVC and instantaneous flows, which were also reduced with no evidence of airflow limitation. His FEV1 to FVC ratio was elevated at 91%. His maximal voluntary ventilation, his MVV, was equal to 93 liters per minute, which was 51% of predicted. And that was reduced disproportionately to his FEV1, which is 3.07 liters, which is unrelated to effort. Measurements of maximal inspiratory and expiratory occluding pressures at TLC and RV were significantly reduced compared with predicted. Now let's do a quick review of the common pulmonary diagnostic laboratory methods to determine static lung volumes. Single breath gas dilution, abbreviated SBGD, methods for static lung volume determinations have not been addressed because they have essentially fallen out of vogue in the realm of pulmonary diagnostics. The exception is the single breath method, which is commonly used to estimate alveolar volume during single breath diffusion capacity testing. Despite its widespread use during the single breath diffusion capacity testing, the single breath method may vastly underestimate actual TLC in the presence of poor distribution of ventilation or unventilated lung. With properly performed testing, using well-calibrated instrumentation, the reliability of all the currently performed static lung volume tests actually reflecting static lung volumes is as follows. Radiographic equals plethysmographic, which is better than multiple breath gas dilution, which is better than single breath gas dilution. Comparing TLC values derived from the various methods is a practical method of laboratory quality control. The laboratorian should suspect the validity of the measurements if the alveolar volume obtained during single breath diffusing capacity testing is greater than the TLC measured with either multiple breath gas dilution or plethysmographic methods. Additionally, the technologist should investigate if multiple breath gas dilution FRC values are greater than plethysmographic VTG. Both scenarios suggest instrument or measurement error, even in individuals who do not have evidence of airflow limitation. Multiple breath gas dilution FRC, however, may be greater than VTG in patients who have either a finite physiologic leak, such as a tracheoesophageal fistula, or a communication with the environment, for example, a ruptured eardrum or a leaking chest tube. Again, it's incumbent on the laboratorian to have some clinical knowledge about the patient being tested. Let's switch gears here and focus a little bit of time on instrument calibration and calibration verification. Each laboratory should establish their own calibration and calibration verification processes. The information on this slide might serve as a point of origin if you're looking for a place to start this process. There are also some great resources published by the ERS and ATS which can provide guidance on establishing good pulmonary diagnostic laboratory quality practices. This figure illustrates a calibration verification using a 3.00 liter calibrating syringe while in the test mode at 37 degrees centigrade. The recovered values were obtained on a single day after the spirometer was calibrated. A simplified method for calibration verification is as follows. A 3.00 liter calibrating syringe is attached to the calibrated spirometer system, and the syringe volume is introduced at varying flows. The resultant FVC is evaluated for acceptability. Both syringe emptying and filling volumes were assessed. This example only shows evaluation of syringe emptying volume. The recovered values range from 3.00 liters to 3.05 liters, which indicates a positive bias, using syringe emptying flows from 1.61 liters per second to 14.88 liters per second. Just a quick note as part of good laboratory practice, a different or separate calibrated syringe standard should be used for calibration verification. The ideal syringe would also be larger than the one used for calibration, for example, a 7-liter syringe. What's the rationale for this? Well, if the same calibration syringe was used for both the calibration and calibration verification processes, the same amount of error would always be introduced. Unless the spirometer system was completely out of control, small system errors would never be detected. This figure illustrates isothermal lung VTG quality control results plotted over a period of time. A lung analog with a constant and known volume is used to simulate a subject's lung volume. Note how the recovered volumes fall within plus or minus 5% of the predicted value, which was 4.144 liters, which indicates acceptable instrument performance. This figure illustrates biologic control VTG quality control results plotted over time. A healthy volunteer is used for serial testing to evaluate the stability and accuracy of derived plethysmographic VTG. This information can be compared to serial measurements of multiple breath gas dilution methods for functional residual capacity and the differences in systems evaluated. Ideally, there would be a number of healthy subjects serving as biologic controls. Okay, here are some final thoughts regarding static lung volumes and capacities. Measurement of static lung volumes and capacities remains an important tool to verify and quantify the existence of pulmonary dysfunction. The utility of these measurements, however, is dependent on the knowledge and skills of the technologist, who must ensure that the equipment is operating in an acceptable fashion, as well as ensuring that the subject is performing the tests as directed. The technologist, as well as the physician interpreting the final results, must be cognizant of the limitations associated with each procedure employed in the testing process, and be able to verify if the derived data are compatible with the patient's clinical presentation. Laboratories are encouraged to develop their own quality control programs and monitors to ensure testing is in accordance with published standards and recommendations. By standardizing the testing process, variability is reduced. Ultimately, test quality and patient management will improve. The next two slides are suggested readings which support the topic of static lung volumes and capacities. If you're unfamiliar with these readings, a screenshot of this and the next slide may be helpful as a future resource. As promised, more suggested readings. The next two slides show some supporting information on the importance of measuring static lung volumes and capacities. This information may be found in the Resources section of the Pulmonary Diagnostic Laboratory Resource Center located at pftlabresources.com. Supporting information is located in the following focus areas. First of all, indications for pulmonary diagnostic testing / review of services. Secondly, airway mechanics, airway resistance, airway conductance, specific airway resistance, and specific airway conductance. There's also a YouTube link listed for the video entitled The Clinical Application of Total Body Plethysmography Airway Mechanics Measurements. And the third area is bronchial provocation method selection, an evidence-based approach, which includes a YouTube video having the same title. And the fourth section, which provides potential applications of static lung volumes and capacities, can be found in the technologist-driven protocol focus area, which provides a number of technologist-driven protocol examples, as well as a YouTube video entitled Technologist-Driven Protocols, Bringing Added Value to Pulmonary Diagnostic Services. The important topics focus area contains video links to presentations provided by key opinion leaders in their respective fields, which may offer additional information on how to improve the delivery of your pulmonary diagnostic laboratory services. Okay, that's it. Thanks so much for taking time out of your busy schedule today. Hopefully there were some new insights or some information that supported what you already knew. Either way, please share your thoughts. My contact information can be found in the Pulmonary Diagnostic Laboratory Resource Center located at pftlabresources.com. Also, while on my website, check out the other focus areas by double-clicking on the Resources tab. Take care.